So let me share my screen and I'm going to show you what we'll be discussing today. Perfect. Okay, so this journal club is slightly different to previous journal clubs if you have joined us before. Today we're not going to be discussing a paper as such, we're going to be discussing the very important topic of COVID-19 vaccine equity and distribution globally. As surgical trainees and anaesthetic trainees here in the UK, we've obviously been quite involved with perioperative care of COVID patients, and of course conscious about the distribution of the vaccine here in the UK. But as parties interested in global surgery, we felt it would be a really interesting topic to discuss. And we've got a really interesting panel who've joined us for you to discuss these things with you, and I'll introduce them shortly. Joining me from GASOC, we've got Dr. Delphine, Dr. Reema Patel, and Miss Ore Bajoma, all GASOC members or previous GASOC members joining, and you'll meet them as we go through the panel discussion. So welcome. So as I said, we're a UK organisation. We run journal clubs. We've got a few events coming up in the next few months if you have a look at the website. The next one is on anaesthesia, and then we've got our conference, our yearly conference coming up later in the year. So this journal club is of course on a topic that we deem to be really important, and we wanted to hear from a variety of perspectives on this issue. And we therefore have speakers from Kenya and also from the UK. So Miss Gatwiri Murithi is a speaker that will be joining us from Kenya. She is currently a project manager for safe surgery and anaesthesia. She's worked there for many years and is very experienced in providing safe surgery and anaesthesia and the concepts and facilities needed. So she will be joining us. We're also joined by Dr. Sarah Okia, who will be joining us again from Kenya. She's the head of Department of Anaesthesia for Critical Care at County General Hospital, and she will be giving us some of her experiences on the ground and also her thoughts on the distribution of the vaccine and vaccine equity, and if she's come across any barriers on the distribution. And finally, we'll be joined by Professor John Ashton. He has a wealth of experience working with Public Health England. He's also contributed to the COVID task force in Bahrain. And you may have come across his book, or if not, you will during this talk, which is Blinded by Corona, which he wrote on the UK response to the COVID-19 pandemic. So we welcome questions, so please pop your questions in the chat box, because what we'll do at the end after our three speakers have spoken is to open it up to the floor for questions, have a bit of a panel discussion. So if you do have questions for specific speakers, do please put that in, and if not, if it's just a general question, then put that in too. You can also join us on Twitter, a Twitter tag is there. And if you do have any feedback, we welcome it either on Twitter, but also remember to do your feedback forms at the end in order to get your certificates. So I think we're going to start with Dr. Sarah Okiwa, if that's okay with you. I think we've probably made you co-host as well if you have any slides that you wish to share, but otherwise you can take it away.
Thank you very much. Maybe I can share a slide.
So I've just made you co-host, Sarah, so hopefully you should be able to share screen at the bottom of your screen.
All right, sure. Good evening. It's 9 o'clock here in Kakamega. Thank you for this great opportunity to do this presentation. A little bit about my experience with COVID So by way of introduction, my name is Dr. Sarah Okia. I'm an anesthesiologist working in Kakamega County General Hospital, which is in Kenya. In a bit, we'll have a look at a map that will just give you an idea of where that is. I also work as an adjunct lecturer at a university that is within the city, the School of Medicine, which is pretty new. Actually, the first group is beginning the third year. Also working in a private hospital as a head of clinical services within the Kakamega. It's a pretty new hospital, actually. And I have some experience with training simulation and also BLS, SELS, which are basically American-based trainings on resuscitation. So that one just is a glimpse of the various institutions that I am aligned to. Yeah. So the picture on the top left is actually the hospital where I work, which is the county hospital. And in the recent years, they have built a level 6 hospital, but it is still under construction. At some point during COVID, we hoped that we will be given some floors to open our COVID ICU, but that is still in the making. And then there is the Masinde Muliro University, which has a School of Medicine, and the Oasis Multi-Specialist Hospital. So just a brief one, that is the map of Kenya, and what is marked as red is Kakamega. It's just about 1 hour to the lakeside city of Kisumu, where Ms. Gatwiri works at. So into my experience, I wouldn't quite say that I have a major experience or the kind of experience, for instance, that the physicians in the UK have had, the US, and even within our country, because being a relatively small hospital, we don't quite have a lot. So before COVID started, we had a 6-bed ICU with 1 medical officer and 1 clinician and 24 nurses, and were able to manage it. Then COVID came and we had to make a makeshift ICU specifically for COVID. And so we created a 3-bed ICU, which had 1 bed space being as a holding bay, because we had issues with waiting for tests to be confirmed. And so we added 2 medical officers and started to train them for critical care experience. We also had operating rooms, 3 of them. 1 was specifically for maternity, and 2 for all other surgeries. And we were running 2 theaters 24 hours. I'm assisted by 9 non-physician anesthetists. So just a brief concerning COVID. So far, Kenya has had about 145,000 Kenyans admitted and isolated for COVID or coronavirus disease of 2019. Of that, about 500 have been admitted at the Kenyatta University Teaching and Referral Hospital ICU, which is the biggest ICU catering for COVID patients. It's about a 20-bed ICU, right? So just to give you a global idea so that you can understand where we are. And as a hospital, so far in the last 1 year, we've only been able to admit 200 clients, mostly because when COVID started, some of the patients were isolated in peripheral hospital centers. So, so far, we've only admitted 8 clients into the critical care unit within our hospital out of the 200 that were admitted. And we unfortunately have lost 2 and 6 have made it. Just additional statistics is that around 4,500 healthcare workers have tested positive for COVID, and 36 have actually died from the disease. In my case, about 7 staff members have have died from COVID-19. So in terms of the clinical management for COVID-19, initially we would intubate the patients and put them on mechanical ventilation. But as more information came about and when we came to realize the outcomes were not good, especially because we compared with other centers that were high volume centers at the time, especially the County General Hospital, Mombasa, which is a coastal city, and Nairobi, we came to realize that outcomes for patients who were put on mechanical ventilation at the first admission, the outcomes were pretty much poor. So we changed to putting the patients on high flow nasal cannula and keeping them on those unless they actually require mechanical ventilation, when nothing is working with that. So in terms of the treatments that we use, we didn't quite have much on our menu. So we would put the patients on the zinc sulfate, dexamethasone, enoxaparin. We would put them on a mucolytic, mucosulfan. Then we'll do ulcer prophylaxis and plus or minus antibiotics depending on whether there was bacterial co-infection. Then a few clients have been able to afford remdesivir, and only one client actually had for their treatment. And also we pruned our patients. Our clients actually with our tests delaying up to 5 days sometimes once the nasal swab is taken, nasopharyngeal swab. So in the initial phase, what we did is that we started changing, and any patient who had suspicious respiratory disease, and especially on chest x-ray, when they were found to have atypical pneumonia, some of them would do high resolution CT, that is computerized tomography. And if we had features suggestive of COVID, then we will treat that patient as such. However, we put them in a waiting bay. So we cohort them so that we await the PCR tests. Then in terms of additional tests, actually our test menu is pretty lean. So apart from the radiological tests, what we are able to do is to do a hemogram. And one of the things that we saw that was consistent is that most of those patients with occlusions, with exclusion of those with bacterial infection, co-infection, most of them had neutropenia. And generally the WBC count were pretty low. And that was it in terms of our test menu. We had even challenges to do blood gas analysis so that we can be able to assess our patients. But as time went by, we were able to access blood gas analysis. So like I said, we have had 8 patients, and out of those 6 have done well. One success story, we had a lady, a 50-year-old lady who was admitted with diabetes, hypertension, and he actually stayed with us for over 50 years. We managed to discharge her sometime in December. And even during her stay, she developed pulmonary thromboembolism. She was one of our first clients actually, and we managed to extubate her, and she went home. She was one of the few clients who we had favipiravir for her. I think she had contact with a chest physician who was able to get us favipiravir, which we did for 5 days, and she did well. One of the biggest challenges that we had with her during that time was 2 things mainly. One is that her blood pressures were kept fluctuating actually. One moment, especially when they get a dose of favipiravir, they get severe hypotension, then they go back to their hypertension. And so it was basically a swing up and down. And also with the PTE is that as we kept adjusting the dose of the thromboprophylaxis, the antithrombotic agent should get bleeding tendencies, but we succeeded. Some of the challenges that we experienced, as I mentioned, we had delays in PCR results for SARS-CoV-2, and we would get delays up to 5 days. So what we would do is that for patients who are suspected to have COVID-19, we'd put them in a holding area where we would start preliminarily treating them as COVID clients until the results were out. And some we used the high resolution CT as a way to diagnose what was happening. The other challenge that we had is that the 3-bed ICU I mentioned was actually a makeshift ICU, which initially it was an isolation ward for infectious disease, and then we converted it into ICU just by putting oxygen, piping oxygen to it and putting ICU beds with the associated machines. So the challenge we had is that because of the nature of the room that we could not dialyze, and in fact, one of our first clients we had to refer out because he went into acute kidney failure and we had to transfer out. We also had difficulties to accessing radiology because the rooms were not designed for instance, for portable X-rays to come in and out. They were pretty small. But from that, we had a discussion with the county to equip a 10-bed ICU. As you remember, I told you we had eyed actually one of the floors in the new hospital that is still being built to create a 10-bed ICU. That hospital has not been finished. However, we have now a 10-bed ICU that is fully equipped. It's actually just they're doing minor finishings, yeah, in terms of electricals and water, and we'll have a full-fledged 10-bed ICU for COVID patients on top of the initial 6-bed that we had in the hospital, complete with radiology, portable X-ray. It's able to do blood gas analysis. We have ultrasound machines in there. We have 2 dialysis ports in that new space. So, meaning that it was not all gloom. Because of that, Kenyans in this region are going to have access to critical care space. Of course, with that, the challenge that we still have is the issue of staffing, but it's something that we are having discussions and having some staff going for training, especially in the nursing team, encouraging them to go for critical care training. And for the medical doctors and clinicians, we are doing on-job training for them. Then we had challenges with the PPEs, but through collaborations with the government, the Kenya Association of Anesthesiologists and a local bank, that is the Equity Bank, were able to be supplied by PPE to cater for our PPE needs. So as I mentioned, the issue of staffing, we're actually doing a lot of on-job training. We were able to get some material that can be of use to train clinicians and nurses on job through the help of the USAID. So far we've not had a confirmed theater undergoing any form of surgery. However, we assumed that any patient who is admitted into the operating room is possibly a COVID patient. And so we ensure that every anesthetist is provided with a respirator mask. And of course, we prefer regional anesthesia and only do general anesthesia with the intubation as the last resort. In terms of regional anesthesia, our menu isn't that huge. Mostly it is just spinal anesthesia and occasionally local anesthesia. The other challenge, being the only anesthesiologist serving a population of about 1 million people in this area, and probably more because we are a regional referral center, and managing the COVID ICU, the non-COVID ICU, and the theaters. Literally, I had to run around quite a bit. we've had 3 surges in July, November, and even currently now. So basically, in the way that I work is that for the theaters, whenever the numbers go pretty much high, then we avoid elective surgeries and stick to emergency surgeries. And so I'm called in to assist where the non-physician anesthetists are not able to handle the cases. And I dedicate at least 2 days in a week to support, especially on Tuesdays and Wednesdays. Then the rest of the week as the need arises. And then of course I have to make time to review patients in both ICU, and in the process also train the medical officer and the clinicians in the COVID ICU for the season. So the other thing that has been of help to me is that there was one of the clinicians is trained has a diploma in emergency medicine and critical care. So it's been pretty much handy supporting me. Maybe I can just say a thing or two about the vaccine. Through the COVAX facility, Kenya has been allocated Oxford AstraZeneca vaccine, about 3.56 million doses. And out of that, we've received 1.02 million doses from as of 6th. So we are expecting the second batch until we have that. And therefore, we are in phase 1 of vaccine distribution. There are also some discussions about getting other different vaccines to be distributed through the private sector. So for phase 1, we are currently vaccinating health workers, security officers, teachers, adults above 58 years of age, and Kenyans with comorbidities. The target was actually to reach about 208,000 healthcare workers. So the distribution is through 9 depots to the counties and then to the sub-counties and therefore to the different hospitals. Some hospitals actually are like some form of referral center. And so people go into those hospitals to get a vaccine. Good news is that I have received my first dose and I'm awaiting my second dose sometime in May. And many other health workers have actually received their doses. As we speak, about 56% of the healthcare workers in Kenya have received their COVID vaccine. The biggest challenge that we've had with the vaccine distribution, interestingly, is that there's been a lot of vaccine hesitancy. Initially, people were pretty much scared because of side effects. Especially people were worried about thromboembolism. So as we speak, it's been a month now, because from the 6th up to date is about a month and a week, and 56% of healthcare workers have been vaccinated and only 20% of the teachers have been vaccinated. Nairobi County, which is the capital city county, is actually one of the area with the highest uptake, but it's also related to the fact that they have a highest infection rates. So at least the people in Nairobi take COVID with a little more seriousness than the people in the villages. Actually, interestingly, people in the village think that COVID is not in the community, it's probably in the cities. Yeah, so those are some of the things that we have to talk to them out of. Yeah, so there was quite a delay of about 2 weeks where the first people who took the vaccines, then others waited to see what will happen to the ones who took the vaccines. But now, as more people are beginning to realize that the vaccines are relatively safe, then more of them are getting. And also with the COVID numbers going up and the Ministry of Health is using other methods, sensitizing the healthcare workers and through the public health systems, and also through some adverts. So more people are more keen to get the vaccine. The other thing to think about, is it possible that vaccines are being hoarded? Because if you look at the national tallies, we are barely at half of the vaccines. But when you ask some health workers, they'll tell you we went to the hospital and we were told the vaccines are finished. So it's something to think about as well. Then I think there was a question about whether or not patents are, a patent hinders uptake of vaccines, for example, of any or any other treatment. I don't think so. I think that patents are important because science has to be funded somewhat, and that is one way that some of these innovations are funded. And the other thing, my opinion though, is that some countries are too complacent, yeah? And they will want to hide under the titles of low income countries so that they don't have to do anything for their people. For instance, the African Union in 2001 via an Abuja declaration agreed that 15% of all the African countries' budget should be spent on health, but Kenya is barely spending 5% of its budget, all right? And if you were to compare Kenya, for instance, with the UK in terms of GDP, then the GDP of UK is 25 times that of Kenya. So it doesn't necessarily mean that they have nothing to spend on health. It's probably just their priorities. And these are some of the things that as health workers, we can be of help through lobbying. And we are having lobbying even through some of the associations such as the Kenya Society of Anesthesiologists. They're pretty much instrumental. Yeah, so what I would actually recommend, instead of taking away patents from vaccines, for instance, you can look at economies of scale and say, maybe by a factor, a certain factor X, these countries' GDP is lower than that. So you can base that to determine the prices of the vaccines. And also based on that country's population, then you can distribute. But I think that every nation should spend and pay for their vaccines. Thank you very much.
Thank you very much, Dr. Kiwa. That was really insightful, and I think gave a very good overview for those of us seeing a probably similar pathophysiology in COVID, but maybe a different experience here in the UK. And thank you for your points on the vaccines. I think we'll come back to some of the issues that you've raised again when we do our panel discussion. I'm glad to say we've been joined by Gatwiri Murithi, who will also continue our talk about vaccine distribution with some slides that she's prepared. Gatwiri, can you hear me okay? We might need to give her a few minutes.
Yes, I can hear you. Yes. Can you hear me?
We can hear you. Thank you for joining us.
Yes.
So I think you should be able to share your screen.
Okay. Just give me a minute.
Yeah.
Screen. So I hope everyone can see my presentation. Perfect. So, so thank you again to GASOC UK for the invite. I am really privileged to be on this panel just to share my experience and what I believe we can do to promote vaccine equity. And for me, this issue is not just vaccine issue, it's actually a health system issue. So in Kenya, I work as a project manager, and my day-to-day activities surround making sure that we are working towards increasing our anesthesia workforce. And working in this field has shown me that the problem is not just a human resource. We need to build a strong system if we if we are to meet the challenge of making safe surgery and safe anesthesia accessible to everyone. So I'll be speaking about this issue from a health systems perspective. So COVID-19 was a wake-up call for everybody. It caught people unaware, and even the countries that we expected to be very well prepared for any eventuality in regards to healthcare delivery, like the high-income countries, were all greatly affected by this pandemic. So while in the high-income countries, the impact has been felt more on the health sector, healthcare delivery, in the low-income countries, as much as our numbers are not as high, it's really affected the social, economic, and even physical life of the people living here. So for example, I live in Kisumu and I cannot see my family who are in Nairobi because of a lockdown. So it's really affected other aspects of our health. And as WHO defines health, it's not only the absence of disease, it's the social, physical, economic well-being of a human being. So COVID has shown us that our health systems, no matter how strong, are very vulnerable to the risks brought on by novel health crises. So where are we in terms of vaccination? So around 161 countries had started vaccinating, and this number continues to rise. So this was when I prepared this presentation, but I think as of today there are about 180 plus countries that have started vaccinating, and it's a mix of who is doing what, and unfortunately, information is not flowing as well as it should be. So while we know the countries that are receiving the vaccines, information is not very clear on how many are fully vaccinated, how many have gotten one dose, how many doses have been delivered to the people who actually need them. So for example, in Kenya, we received about 1.02 million doses on 2nd of March, and by 11th of April, we'd only administered 48%. So there's clearly a challenge when it comes to actually making sure that these doses reach the people that they were meant for. So in terms of percentage, we've only managed to vaccinate 0.8 of the eligible citizens. So we are really, really way behind in terms of making sure that we reach that critical mass of people that will ensure that we've vaccinated and reached a place where we can say there's herd immunity and we can protect each other without having to socially distance, wear masks, and do all those other preventative measures that we've been encouraged to do from the beginning. So there's an African proverb that says, a tree cannot stand without its roots. So there are vaccine delivery needs a strong foundation for it to be successful. And so I want us to look at what it takes to deliver vaccines to the people who need it. And as I said at the beginning, I want us to look at a health systems approach. So I know many on this call are medics, and you know that when you see a patient and you examine them physically, what you see, what you hear, what you smell, what your senses tell you are a symptom of something that's happening real deep inside. And we need to look deep within our health system and find out what is not being done correctly that is making this access to vaccines weakening the system that delivers vaccine. So I'll show you 3 maps. The first one is, I'm sure you all know these maps. The first one is the distribution of surgeons, anesthesiologists, and obstetricians. And as the saying goes, the grass is always greener on the other side. So the goal for all countries should be to be as green as possible. The minimum standard is 20 per 100,000, but clearly, when you look at Africa, we are way, way, way behind when it comes to the numbers of surgeons, anesthesiologists, and obstetricians. The next map I want us to look at is the Wfsa Workforce. This one was published in 2017. Again, when you look at sub-Saharan Africa, we are red, and that's a clear sign of danger. I think irrespective of where you go, red does not bode very good things. It's a sign that there's something that's missing. So when you look at the third map that shows COVID vaccines per 100,000 that have been administered, it's a reflection of the first 2 maps I showed, where the workforce is sparsely populated. It reflects the same with the vaccine distribution. And this is a sign of a very, very weak health systems. And for me, for a strong health systems, you'll build buildings, you'll equip them, but if you do not have the human resource, then you are not able to deliver the kind of quality care that is needed for those people. So like these other maps show us clearly there's a weak system in sub-Saharan Africa. So before we even try and fix issues to do with vaccine equity, we must look at the system that enables these vaccines to get to people. So what does a system for vaccine, getting vaccines to people look like? There are 4 main aspects of that I wish to touch on. And I know there might be more, but we'll just look at these 4 key areas and see where we are as people living in sub-Saharan Africa. So those 4 key processes are research, manufacturing, cold chain delivery, and ultimately vaccination, which is delivering the service to the people. So where are we as sub-Saharan Africa? In terms of research, we are limited to conducting clinical trials. There has not been any R&D for new vaccinations being done here, but we have participated in clinical trials, including the ones for COVID-19. In terms of manufacturing, our capacity is way, way, way below what is truly can be said to be adequate. So less than 1% of the vaccines given in Africa are actually manufactured here. So think of a scenario where you have a meal that is on your plate, something that you use to sustain your life. And imagine if all the ingredients, except for if the meal comprised of 100 ingredients and only one of that ingredient was found in your country, what does it say about the security? How food secure are you if only 1% of the food that you consume is sourced from your country? So it's the same with vaccines. We know that a strong vaccination system is important to ensure that things like infant mortality, child mortality rates are kept at a minimum. But if we are depending on external factors for 99% of that service, then clearly there's a problem. And if anything happens to that supply chain, then we are really, really at a disadvantage. There are only 5 out of 54 African countries and regions that actually have some form of vaccine industry. So what does that even mean when people say that one way to achieve equity is by removing the patents for vaccines like the ones for COVID-19? Do we have the capacity to actually manufacture those vaccines locally? So with just 5 countries with industries, then clearly we need to really think through and think, what do we need to do to make sure that our manufacturing capacity is strengthened. In terms of cold chain delivery, we've had modest success with that. We have a strong EPI program in Africa where children under 5 receive all the prerequisite vaccinations that they need. The only challenge there is this program is largely supported by external partners. So one example is I found was of Ethiopia, where their budget is about 150 million. And of that, 2/3 of the funds come from external parties. So what happens when those external parties no longer feel as philanthropic as they are right now? What happens to that program? So if that funding ever dries up, that means the government will be left with that 2/3 gaps in their budget. And as Dr. Sarah mentioned, the healthcare spending in the health sector from the government sources is way off what it should be to make sure that we have a sustainable system. And lastly, vaccination delivery. So as of now, we are at 72% for all vaccines, but this number has stagnated for a number of years. And with a growing population in Africa, our demographics are changing. By 2050, we are expected to be about 25% of the global population. So the gap between the served and the underserved will keep on growing if nothing drastic changes in terms of our health systems. But there is goodwill, there is a policy commitment, but now we need to move from policy to actually practice. So I did a little mapping. I'm sure everyone has heard the word COVAX. COVAX hopes to bring in economies, regardless of whether you're high or middle or low income, together to have a collective bargaining power to purchase these COVID-19 vaccines at a reasonable rate. And they partner with organizations like CEPI, the World Health Organization, Gavi, which is a huge funder for vaccination programs in Africa, and UNICEF, which is the main procurement agency for vaccines in Africa, and also our governments. So that's why I've put in the logo for the Ministry of Health in Kenya. So some countries are doing direct bilateral agreements with the manufacturing agency beyond COVAX, just to make sure that they have enough vaccines to get to their people. But as you can see, when you're mapping the partners, a huge chunk of the partnerships that we have are external donors. And we need to ask ourselves, is this a sustainable model? Because we will deal with COVID now, but what happens when the next COVID comes up? Will the sources that have supported us now still be willing and able to support us then? So we need to think beyond COVID. And so I found this diagram on Twitter, and I thought it's a very good explanation. So the outcome that we want is vaccine equity, where regardless of where you live or your income level, you are able to access the best possible healthcare, including COVID-19 vaccines. That's the outcome we want to see. But under this outcome, there's an iceberg called systems, and these are the ones that will make or break the impact that the volume of the outcomes that we want to see. So let's looking at the systems systems-based approach to using a systems-based approach to equity. For me, this is what equity means. So I used the word equity as a mnemonic. I know in medicine you use the sounds a lot. So for me, E stands for education. We need to build capacity in low and middle income countries to do their own R&D, to train their engineers who can convert the existing manufacturing capacity into vaccine companies if need be. So for example, in Kenya, we have a very strong vaccination manufacturing industry for the veterinary program. So we have a parastatal in Kenya that actually produces vaccines for animals. So if we had the capacity to actually transform that existing factory to actually transition to also produce vaccines for humans, do we have the technological know-how to actually do that, or will we rely on high-income countries to come and give us that kind of support? For Q, for me, means quality. If you're going to strengthen your manufacturing and R&D, you need to make sure that it's of the best quality, that no one can question the validity of your scientific results. They cannot question the validity of your clinical trials for your vaccine. They cannot question the validity or the authenticity of your manufacturing process, and people will actually want to even buy the vaccines that you produce. So can Africa produce its own vaccines for its own consumption and also to supply beyond our continents? The U for me stands for utilities. So the same utilities you need for the cold to sustain a strong cold chain delivery systems are the same ones you need to sustain both healthcare services delivery and vaccine manufacture. So this is things like electricity, water, communication, and transport. So I'm sure many of you have seen stories of the struggles that even Kenya is having with like their oxygen system. So we have always had a challenge with oxygen services in Africa and in Kenya in particular. And COVID has just made these things worse and brought it to the attention of the public. So going forward, are we going to build up the infrastructure that is needed to actually not only increase our capacity to sustain our oxygen needs, but also make sure that we have enough utilities to even run a strong healthcare system that can provide the quality healthcare that people who are suffering from COVID actually need. For me, I is investment, and this one should cut across all these other letters. So as I said before, we have been so dependent on external support to sustain not only our existing vaccination programs, but also this COVID vaccine rollout in Africa. Sorry. So going forward, is this a sustainable system? Are our governments willing to increase their investment, not only for the current crisis that we're facing, but in preparation for future crises? And they need to do that by investing in education, investing in manufacturing, and investing in the utilities that are needed to sustain a strong system. And for me, T is transformation. So as I mentioned earlier, Africa's population is growing. We will be home to a quarter of the world's population. So while we know that maybe our needs for the COVID vaccines right now are very modest, what will they be in 2050? We need to think about that and know that the status quo where we are so reliant on external factors to give us the support and strengthen our system every time we have a crisis will not work. So we have to transform the whole system from top down, build our HR, build our infrastructure, increase, reduce the distance that people have to travel even to access their healthcare facilities. So it's a total transformation to be able to deal with those things. And if we don't deal with them, the gap between the served and the underserved will just keep on growing on our continent. And the last one is why. I know why does not start with why, but we must always be guided by why are we doing what we're doing. For us to demand for vaccine equity, we must ask ourselves, is what we are doing sustainable? Will what we are doing now make sure that not only will it serve me, but my children and my children's children? We have always to think about the next generation, and our whys should always be looking far ahead, because what we do today has a ripple effect to the next generation. So there's an African saying that says, a bird that flies on the earth and lands on an anthill is still on the ground. So we've made progress. We have a vaccine now. We are rolling it out, and hopefully in the next few months, fingers crossed, we shall actually have overcome this challenge. But shall we have made changes, significant changes, that when the next COVID comes in, we shall be able to actually deal with it as effectively and faster than we have done right now? Have we learned from our mistakes, and are we prepared for the next crisis? So we might pat ourselves on the back and say, we have done a good job, but we are still on the ground. We need to soar above this crisis and make sure that we have a health system that is unshakable, that can sustain any shock effects from anything new, because the world that we are in needs that kind of thinking. We need to think in the future. So those are my references for this talk, and I welcome any questions and comments. And again, thank you very much for the invite. Over to you, Kat.
Thank you very much, Geturi. That was really, really great. I know we've had some really great comments about the slides, so thank you very much. I think we'll ask all of the questions at the end, and we'll do kind of a panel discussion. I know we have a few already. Based on what you said, we'll discuss things a little bit further at the end. So next we're going to hear from Professor Ashton, who has joined us from the UK, from Yorkshire, where I hope it has now stopped snowing, as it was snowing there a couple of days ago. So we'll hear from him with possibly a more UK side slant, possibly from public health perspective, but I'll let you, I won't try and give any spoilers, Prof. Ashton. So when you're ready, you can take your microphone off mute.
Well, thanks, Kat, and thank you for inviting me, and very interesting contributions from Africa. How long have we got now? Because we've had about an hour, so I'm not sure what we've got left.
20 minutes, half an hour, and then we'll do a half-hour kind of question.
My God, I thought I'd be able to retreat before long. Right, okay.
You can speak for less if you want, because I think we will have quite a few things to discuss in the panel discussion. So
I think there's a lot of food for thought in the contributions there, and I just reflect on each of them first, and then say some other things. I think. There's so much we don't know still about this virus and this pandemic, and a lot of the comparative epidemiology and public health about the experience in different places is still not well described. It seemed earlier on that Africa was getting off quite lightly, and we don't really know. I mean, in South Africa, it seems to be bad. But from what we heard from Kenya, it didn't sound as though the impact was so great. You know, understanding if that's the case, but it may not be the case as we experience further waves of the COVID pandemic, we need to understand that better. I mean, we've heard quite a lot in recent months about vitamin D and about the protective aspects of that, particularly for darker skinned people living in the northern hemisphere. And I will come back to the preventive side of this, but I mean, some of the healthcare issues that are important to bear in mind when looking at somewhere like Kenya and Nairobi and so on is what is the real measure of the need in the population? Do we know it? The basis of public health is data, and it is statistics, and it's actually knowing how many people actually are out there suffering, and how many people are in contact with services. So whether that's about the services themselves, the levels of funding, the levels of investment, whether it's about access. And I think one of the worrying things on the vaccine front is that once the private sector becomes a significant player, as we've heard that it may be in Africa, then there's a real danger of exacerbating inequality, that the people with money will get access to vaccine irrespective of whether they should be seen as a public health priority. So that's an issue which I think we need to flag up at this point. I was, you know, taken by the presentation on vaccines, and I think just before I forget to mention it, I mean, I think the whole notion of self-sufficiency is really important, and the idea that actually re-engineering the veterinary pharmaceutical industry, the virology, the vaccinology side of veterinary industry in Africa could be really important. I mean, in terms of the move to self-sufficiency. But what we have to remind ourselves of is that, in a sense, the need for vaccines, and this has particularly been the case in the United Kingdom, the need for the vaccines has been because of the failure of public health. At the very outset, traditional public health was not mobilized. You have to remember that until 1 or 2 generations ago, we had to deal with pandemics, cholera, typhoid, tuberculosis, all these kind of things. We dealt with them by a combination of environmental measures and hygiene measures. And the early public health people in the 19th century, which were to be found, copied, and you know, systems built on the model throughout the British Commonwealth of public health in the town hall, was based on identifying where cases were and isolating them and preventing the spread of the virus. Decades, and in fact 100 years before we had vaccines, and we dealt successfully with pandemics using those kind of measures. And those measures were not deployed in the United Kingdom for the first half of this pandemic, because we'd allowed our public health system to be run down, and we were viewing the pandemic through the lens of hospital medicine and of high tech and of laboratory science, which is why in the end the British were successful by investing so much in vaccines. But in the meantime, 150,000 people died because of the failure to do the basic public health. So we have to see vaccines as being the icing on the cake of the endeavor. They are not the main project. And when you look at Africa, we've heard Africa, heard about the expanding population, although fertility is coming down. These projections may not be as accurate as all that. But we're talking about nutrition, we're talking about poverty, we're talking about overcrowded, insanitary environments, we're talking about rapid urbanization, we're talking about the encroachment of slums into jungle areas, we're talking about people mixing with animal food chains, with the viruses jumping species for zoonotic transfer, and we've got to address that. So I just, I don't wish to detract from the contributions that we've heard. The vaccine issue, the equity of access to vaccines is very important, but it has to be seen as part of a total approach, which includes very traditional public health with attention on the environment, on hygiene, on shoe leather epidemiology, on counting the numbers, on knowing where the issues are, in focusing in on them, and in seeking out and destroying the virus wherever it is through measures that can include vaccines. So one of the questions as well is, who should be getting the vaccines? And we hear at the moment, this conversation this evening is about vaccine equity at a national level. But when we talk about vaccine equity at a subnational level, and when we look at the UK, for example, the majority of older middle-class people in the UK have had their vaccines. A lot of the people who haven't had their vaccines in the UK are poor people and people living in disadvantaged areas. And we know that the system that you have, I mean, that's with the British National Health Service, the system that you have can make that worse. If you have a system where private medicine is dominant, then the people with the money are going to get the lion's share of the vaccine. You have to have very interventionist government to stop that from happening. And we know that in countries that have had access to relatively limited supply of vaccines so far, it's likely that the people who will have got it will have been the politicians and the business leaders and the army and the other people who are in powerful positions. So we have to address those things at the same time. I can't defend the British approach to vaccine procurement. I think it's obscene, the fact that we have procured enough vaccine to vaccinate everybody in the United Kingdom about 6 or 8 times. And that we've been very slow to share that out. We've really pursued what I think is a flawed approach to the situation now, when half the population has had one vaccine, but we're continuing to use a medical model for deciding who the priority groups are and working down through age groups. So this week, we're now talking about vaccinating the 45 to 49-year-olds. We're not adopting a social model where I think what we should be doing is saying we should be vaccinating all those people who might be potentially spreading the virus because of their being out and about. People like taxi drivers, bus drivers, teachers, the person on the checkout at the supermarket, all those people interfacing with the public and who might be quite young, but who might get the virus and then spread it. And then we might have on our hands the situation where the virus mutates, we get another strain, which might not, where the vaccine may not be effective. And so there's a bigger picture to this, which we have to contextualize when we're looking at this. I think the basic question about equity of access globally to vaccines, there's no argument. That needs to happen. And unfortunately, the global agencies like the United Nations, like the World Health Organization, and certainly the commercial organizations don't have the vision or the commitment or the leverage to be able to make that happen. And because of the world's political situation, which has been fragmenting into small-minded nationalism, then there's not a lot of political will for collaboration at the present time. These are big issues. I'm 73. I hoped when I was your age that the world would be a better place by the time I'd left it. But, you know, sadly, it's become a worse place over the last 60 or 70 years. And it's your generation that are going to have to grasp this nettle. Us old fellas, I'll be right behind you, and we'll give you every ounce of support as you try to deal with these questions, which are so difficult, but which are absolutely so essential to tackle. I'll stop there, and I'm happy to be in the panel just now. So we've got time for a bit more conversation.
Thank you very much, Prof. Ashton. I'm going to introduce two of my GASOC colleagues. Rima Patel, who's listed as GASOC UK, is GASOC President, and she'll be contributing on the panel discussion and helping us ask questions. And Ore Bajoma, who's one of our former GASOC committee members, who has kindly agreed to help us on this journal club. So I think I'll start things off with a question that I put to Dr. Akiwa, actually. You mentioned that you were experiencing, or I suppose that you have seen quite a lot of vaccine hesitancy, either within the healthcare professionals or, as you mentioned, in the villages near your hospital. And I was just wondering how you have seen this to be addressed, or is it being addressed, particularly with regards to the healthcare professionals?
Yes, thank you, Kat. Part of the way to overcome that vaccine hesitancy has been the politicians, you know, they draw a lot of crowds in places such as these. So, for instance, for as long as the senior government people are not seen to be taking the vaccine, then people believe that it could be harmful to the people. And so, as soon as senior government officials came out to say they had tested positive at some point and they took vaccines, the numbers of people went up, including actually, very interestingly, social media. Lots of people actually took pictures of them being taking the jab until it became as though it's a joke, like the vaccine comes with the camera. But now that pushed people to realize, okay, maybe this is not as bad as it were. But at the health level, the hospitals are actually operating through the public health system to give education and to lobby for especially since in this phase, mostly we are targeting the health workers, the security, teachers, people over 58 and so on. And also some adverts that are being used and people are told, okay, so if you are eligible and you fall within this criteria, then you can go to a hospital X or Y and you can get the vaccine and the vaccine is safe. Also, there were adverts through UNICEF where people were coming out to say that these vaccines are safe. Yes, we've been vaccinated, especially the team of health workers working at the Kenyatta National Hospital, which is the main teaching and referral hospital in the nation. So those are the main methods that have been used to address hesitancy, but it's still something that is still there. Also, because one thing to note is that it's also affected by issues such as traditions and people's belief systems, which might be sometimes difficult to undo. Remember, there are those who are there are those who are hesitant just because of complacency, and yet there are those whose belief systems they will not. I mean, they're just keen to follow the conspiracy theories, and they cannot be pulled out of it. You tell them, take your jab, and they'll tell you, I don't want to die from thrombosis. And however much you tell them that those numbers, if you compare the numbers of people who are getting side effects against the benefit, they'll still just not believe you. Thank you.
Thank you, Dr. Kiwa. Prof. Ashton, you have your hand up.
So I think it is a very interesting question, this, and I would just offer a couple of observations. One is that there are two sides to this idea of vaccine hesitancy. It is a real phenomenon, but mostly it affects a small minority of people, maybe 10% or 15% of the population. But the other side of the coin is trust, and how much government is trusted, how much public figures are trusted, how much professionals even are trusted. And we saw in the UK how VIPs thought that the rules and restrictions about COVID did not apply to them because they were too important. And that undermined trust. And I know from my work in other countries that VIPs are a problem. VIPs think that they are not part of the mass of the population, and they think that they can do things that other people aren't allowed to do. So we have to maintain trust. We have to set a good example. Anybody in public life has to set a good example. And that's part of the story. The other part is access. And very often, what gets labeled as hesitancy is because people just can't get there. Their lives are too complicated. They may have lots of children. They may not have access to transport. There may be lots of things going on in their lives. I can remember many years ago addressing this problem with regard to breast and cervical screening among Pakistani women in Southampton. And, the women were not coming. And the attitude of the health services were, these people are really stupid. Why aren't they coming for their service, which is important to them? And, when you actually looked at it from their point of view and culturally from their point of view, it was that their husbands were mostly working on the buses in Southampton as drivers or conductors. The women would not go to the hospital without their husband. And unless you put on outpatient clinics at times when the husbands could not be working and not lose money for not going to the shift to do their work, they wouldn't come. Walk in ordinary people's shoes to understand these questions.
Rima, I think you've got another question from one of our participants. And just to remind any participant, if you do have questions or comments, please pop them in the chat box.
Yes, thank you, Kat. So we've got a question from Rebecca here that says, at the turn of the millennium, HIV therapy cost $10,000 a year, but with compulsory licensing, which was strongly opposed by the drug companies. Generics from India were made at $300 a year. This has massively increased supply in sub-Saharan Africa. Don't we need a similar response by challenging patents now? So I'll go to Gatwiri for that question first, if that's okay.
And let me share my screen again. So this is a photo of one of those generic drugs that is the patent was granted to a company in India, and you can see clearly it's labeled not for use, not for distribution in the US, Canada, or EU. So I got this message from one of my aunts, and given that it actually reduces a level of trust in these generic drugs, and it's very critical to educate our people. So what I did when I got this is I told her the most important part of this conversation is explaining to the people who are actually getting these generic drugs that the main company, which is in this case was Gilead, gives a manufacturer the license to actually produce a generic version of the product, just to make sure that people accept these things. So let me stop sharing. So I think it will be a good idea to do that. But as I said in my presentation, currently in Africa, we have less than 10 companies that can actually manufacture. So in the short term, yes, it's a very good idea. But in the long term, we might need to supplement our manufacturing capacity to be able to actually make use of these patents that are given to us. So you might say, here's the recipe for Coca-Cola, but how many factories actually have the capacity to produce it? So you have to, if you don't address both aspects of it, then it might not have the impact that you want.
Thank you. That is, I think that's something that people actually forget, and I'm guilty of that myself. You know, it's all well removing patents, but actually, if you don't have the manufacturing capacity, then there's not much point. Prof. Ashton, you have your hand up there.
Yeah, well, I mean, what is happening with the AstraZeneca is that they have been working with a number of countries around the world to set up manufacturing, not least in India. And, you know, any question of it being an inferior product, I think that question is tackled by the fact that the British government has itself placed orders with the Indian manufacturing plants for large numbers of doses, I mean, which actually they're not getting at the moment because the problem with the virus is so bad in India at the moment, they're keeping the vaccines for themselves. But, you know, AstraZeneca is producing the vaccine at cost globally. And that is the example that presumably we would like to see. The problems with AstraZeneca vaccine, which look as though now in most places it probably will only be used for older people, means that we need to press on with that, of using the AstraZeneca for older people globally. But we really need a similar initiative with the other vaccines, which may not be problematic for younger people, but which are being made at profit at the moment. We really need to put moral pressure, political pressure on those manufacturers, and interventions were necessary to make sure that the other vaccines are available for the younger populations around the world.
Thank you, Prof. Ashton. We've got a comment from Rebecca here again, who says, thank you. She agrees they need to work on increasing capacity, and through lifting patents and allowing good technology transfer, we will be heading in the right direction to allow for this. Sarah, did you have anything to add with regards to removing patents, etc.?
Yes, I was of the opinion that the patents are still important, since patents are there only usually for a given duration, so that the original manufacturer is allowed time to recuperate all that was used for purposes of building. So in a time such as this, for instance, where we have in the middle of a pandemic, for instance, they can choose to waiver the patent on a I would call it probably humanitarian ground. The way you are talking about AstraZeneca giving companies in India to manufacture the vaccines. But let's assume that at a point in time X, we will be out of the pandemic. Maybe COVID will be like a common flu, and other people will need to manufacture drugs. The people who actually will go out of business if you pull out patents, because every innovation has to be protected. And at the same time, as I said before, when I did my presentation, every country, we can't always hide behind low-income countries. Every country has some ability to buy out, and even as we are being told, as we are discussing with Ms. Gatwiri, we actually have the capacity to manufacture and put some effort in doing this. Some of these countries that are already manufacturing drugs have actually been intentional to put part of their national income on research. So there are countries that they just need to be serious about it, and we will be able to manufacture. But we are like hiding behind low income and then just depending on income on handouts. I mean, in a country where 2/3 of the health budget is a donation, like seriously, what happens if those other nations don't want to donate to you? So for me, I'm a strong believer that patterns should be maintained, but waivers can be done for given scenarios such as this. Thank you.
Thank you, Sarah. I think it's a food for thought, really, with regards to manufacturing capabilities, with regard to removing of patents and actually self-sufficiency from a country global perspective. So that's really great conversation there. I think we'll move to Ore next.
Hello everybody. Thank you for your very interesting talks. I very much enjoyed them and all the different perspectives. I'm just going to ask a question from the chat from Prof. Laku, where Prof. Laku's asked, Prof. Ashton, how do we reintroduce public health to control pandemics rather than going hospital-based? We've seen the LMIC countries do this successfully.
Well, this is am I on? Yeah, it's an ideological battle that's been going on now for, since Alma Ata Declaration in 1977, 81, whenever it was. The need to reorientate health services towards public health and primary care, and which has been an uphill battle. I mean, if you look at the countries that have done well in the pandemic, you look at New Zealand, you look at Taiwan, Korea, China, you look at Finland, you look at Norway. These are countries that have strong primary care, strong community investment, very much a public health orientation. They're not countries that are dominated by hospitals. And we've got to get the balance right. And it begins in the recruitment and education of students of all kinds, medical students, nursing students, all kinds of students, because the assumption, and I got a bit of a flavor of that in the earlier presentations, the assumption is that the hospital is at the center of the healthcare system, when that's not the argument that the World Health Organization has been proposing now for 40 or 50 years, that the front line is self-care, it's family care, it's support for community organization, community development, for health skills in everybody, backed up by primary health care, which is integrated with social care, with education, and so on. And that the hospitals are really the last resort when everything's failed. I think what we saw in England at the beginning of this was the major political driver was the fear that the hospitals would fall over. And all the money got put into trying to stop that happening at the hospital end, building Nightingale hospitals that were never used, that could never be staffed, and then discharging 30% of patients from hospitals, many of them into care homes, many of them infected with the virus, taking the virus into care homes and causing a parallel epidemic in care homes that killed tens of thousands of elderly people. And that was all because of the failure to come at it from the other end of the telescope, from the prevention end, from doing the shoe leather epidemiology, finding out where the viruses were, triaging, quarantining people, not allowing the virus to spread. And, I was working with Bahrain at the beginning, and I saw them doing it properly. And they quarantined people, they stopped travel, they stopped the virus from spreading. And that's what you have to do. So part of the problem is our politicians don't understand public health. Politicians, they live in Nigeria and have good nutrition and a good lifestyle and do live a long life. They benefit most from hospitals because they live long enough to need all the long-term care of hospitals. They live to be 70 or 80 or so. And they're more interested in hospitals than they are in public health, which affects the masses.
Thank you very much. That's a very interesting perspective. I was just going to ask another question to Gatwiri and Dr. Akia about some of the points that you'd raised. So some of the discussions we'd had on the other side of the spectrum about vaccine distribution highlighted on actually what what COVID has kind of just highlighted that we've known for years, that specifically, well, particularly in some low middle income countries, the healthcare systems that aren't strong enough, they're not adequate for built for need, essentially. And my question basically is about, in the meantime, whilst, you know, sort of things such as the Lancet Commission are working towards improving the SAO distribution by 2030, in the meantime, whilst we have COVID here, you know, essentially what can we do to improve that? And I know we've talked about private access being problematic, but actually in countries where they already have a system where private paying patients, that is the norm, is there a role for this in improving access for the underserved, perhaps where people over a certain income had to pay for their own vaccines, and then it was free in LMICs for people who didn't earn as much? And I just wonder whether you think that could be an interesting approach, you know, whilst trying to avoid unfair distribution of vaccines, but just trying to mitigate and reduce the over-reliance on other countries.
I think you're raising some big questions, which would take a long time to do justice to. You know, I mean, in the case of European countries, that journey to national health services took quite a long time. You know, initially, in many countries, it took the form of employers and government and patients contributing in a co-production way to the services that they were able to access. And then in the course of time, either through insurance funds or through direct funding through taxation, led to national systems of healthcare. But I think all countries need to have properly funded public health services. That has to be the baseline. And that's where, you know, we come into this. And clearly the vaccines are a wonderful gift from heaven, you know, at this stage, but they are not the first line of attack. They're not the first line of defense. They are there because we're in a mess. What we need to do, because this virus is likely to be with us for the foreseeable future and it will change and it'll come back, is learn the lessons. You know, we've seen how the adoption of widespread hygiene measures has meant that there's been no influenza this winter in the Northern Hemisphere, because people have become cleaner and they've become wearing masks and have been washing their hands when they've been to the lavatory, for God's sake. You know, that's not a good idea. You know, all the old-fashioned public health lessons have been taken off the shelf. Things that a lot of people thought you didn't need to think about anymore because you had antibiotics and you could just give people antibiotics and hygiene didn't matter anymore. You know, so we've got to rediscover our commitment to fundamental public health. And then we've got to see how to use vaccines and antibiotics and the other gifts that we've had properly and discriminatingly, so that we don't find that they no longer work for us in the future.
That is very true. Prof Laku has also made a comment in the chat box saying that she agrees with your views, Prof Ashton, that we have been going backwards as a society as a whole, and this pandemic should be a wake-up call to go back to the drawing board and public preventative health. So I think Kat's just going to ask one of the other questions that we've had in the chat.
Yeah. Yeah, so I might go back to a question to Gatwiri actually, although Dr. Okoya and Prof Ashton feel free to pitch in as well. We were discussing quite a lot of obviously a top-down approach to both the public health measures that we've been discussing and of course to the vaccination strategies. But I wondered whether you have any thoughts about whether there's capacity for a bottom-up approach, i.e. a role for grassroots organizations, for the public to make some noise about the changes that need to be made, maybe putting some of the responsibility on the public to ask and ensure that all of these measures are being taken. So what would your thoughts on that be? I'll start with Gatwiri.
So thank you for that question. And I think a bottoms-up approach would be ideal, because especially when we're talking about COVID-19, most of the response has been directed by government, and who puts these leaders in power, in those positions to make these decisions on our behalf, if it's not us, the people. So I think we need to be, as advocates in the healthcare field, make sure that our people are more informed about the choices that they're making, that leadership positions should not be made lightly, or we should not disengage from the political process, because leadership matters, and it's us as electorates who give these people the power to make dumb decisions, as I would say. So I think that to start with is very, very important, but also because the only way we hold our leaders to account is through participating in policy development, in advocating for change, advocating for budget. So, for example, in Kenya, we have public participation is actually entrenched in our constitution, where our leaders are meant to actually even come to us when preparing their budgets for the counties. Okay, that's in the devolved system. So our country, we are divided into counties. So they should actually come to us and tell us how they will spend our money. So we should make informed choices and contribute to such discussions, and make sure that actually investment in healthcare is actually strengthened. So grassroots organizations have a role to play. They need to turn every citizens they can into champions for change, to advocate for a stronger health system. When it comes to public health messaging, as Professor Ashton mentioned, it's us who get this WhatsApp forwards with misinformation. It's us who will correct this misinformation and make sure that the right information is circulating, and we are breaking the chain of misinformation. So making sure that we are informed, that whenever somebody sends us a message that does not seem right, we fact check it and make sure that the right information is going out. So I agree, there has to be, it will be a mix of both bottoms up and top down, but both parties have a very significant role to play in making sure that the system works. Yeah.
Has he come? Hello?
Thank you, Botiri. I'll take my take on this one is, yes, definitely we need a bottom up and top down kind of approach. In our setup, because of the political landscape, there's a big problem with the bottom up, mostly because of lots of people who access information that is given them and may not be that educated. And even if they're educated, they may not interrogate every information that is provided them. So they just consume whatever information is given them. So for us as Kenya, at where we are in terms of approach, what seems to be working and what people are doing actually is for associations, like the professional associations, like in the medical field, the medical professional associations, like the Kenya Medical Association and the Kenya Society of Anesthesiologists and all the other professionals in the medical field. What they do is they actually have taken a frontline approach to advising government. Sometimes government may not pay attention to what they do, but a lot of times they gather enough information and enough to be able to sustain the system, because our bottom up is not very strong. For instance, during this COVID season, there was severe shortage of PPE and gloves. And at some point, actually, the associations had to sit down and figure out how to manufacture and even look at the quality of what they're manufacturing. And that is how, for once, we actually had the PPE manufactured in Kenya and distributed in Kenya. So yes, bottom up is probably one of the best approaches, but it depends normally on the political landscape. Thank you.
Thank you, Dr. Akiwa. And thank you, Geturi. They're really useful comments, insightful comments. Prof. Ashton, you had your hand up. You're on mute.
Sorry, I'm going to make a serious point, and then I've got to go and put my hens to bed so that the foxes don't get them, because it's going dark here and they will be going. So I think, you know, we don't have a choice really, or we do have a choice. The world has become very unstable in recent years. And history tells us that after an event like this pandemic, there will be monumental political change and upheaval. You are looking at your generation at unprecedented political and social change around the world. There will be insurrection, there will be revolution, there will be the most horrendous things happen. And if you're a healthcare professional, I believe you have a moral obligation to be part of shaping what comes out the other end, because the choice is either you're on behalf of, you're on the side of the poor, or you're on the side of the privileged. And you need to decide which side you're on, because your voice counts. And it's important to make that choice. We're seeing it in Myanmar at the moment, but we're seeing it in many other countries around the world. And when the dust settles on the virus, there's going to be huge change in countries around the world. And privileged people like ourselves who have professional lives have a responsibility to provide supportive leadership to ordinary people and to poor people, to make sure that they don't fall into the hands of despots, and that the authoritarian people who are just happy to take over and run the world are not allowed to do that. So, you know, we will have to take risk. That's going to be within your lifetime. I'm still trying to keep my voice alive as long as possible. But thank you for having me tonight. It's a really important meeting. You're a very important group because you're taking the flame forward. And don't forget ever that being in health is a vocation. It's not a license to make money and have a privileged lifestyle.
Thank you, Prof. Ashton, and thank you very much on behalf of everybody participating. It was really useful to have you on. And I think someone has just plugged your book in the chat so that everyone has now got a link to your, your book. Thank you very much. We're going to continue with a few last questions for those of you who are still with us. Thank you for staying. So there's a question here from Ryan. I'll just go back up to it. So as mentioned, it has been suggested under 40s in the UK may be advised to use alternative vaccines to AstraZeneca due to reports of adverse effects, so clotting effects. If UK or other high-income nations do engage to redistribute vaccines, how important is the focus on ensuring equal distribution of the vaccine forms of vaccine and ensuring vaccine use among different groups, i.e. age groups, in high-income countries and low-income countries are equal? And this question was furthered by Laura, who added, in addition, I know that there are fears of mix and match vaccines, even there is no evidence for this. With the two-side regime, is there extra fear that in LMICs, people won't have access to the right booster or the right vaccine for their age group? So I guess, Getwiri and Dr. Okaya, what have you, or is there any kind of discussions that you've heard about the possibilities of mixing and matching due to lack of 2 doses of the same vaccine, or is that something that's been discussed that you've come across?
Thank you. That's a very interesting question. As it is, no study has been shown that has been done to see what would happen, for instance, if you took the first dose as your Oxford AstraZeneca and maybe your second dose be a Pfizer. So really concerning that, we are in the dark, and COVID has been as such, we are basically learning on the job. So it is probably something that maybe might be of interest for us to maybe to go into and to study before people can go into it. But definitely when you start fragmenting vaccines according to age groups, then of course there are certain countries that will be disadvantaged. For instance, Kenya, through COVAX, has only access to AstraZeneca. So does it mean that they'll only vaccinate people who are above 40? You see, so for as long as they don't have any other choice, then definitely vaccine equity is going to be a problem. So I think that is a pretty important frontier to look into and see, first of all, if new vaccines can still be created. Remember, I think the Oxford AstraZeneca covers for the UK variants, but it's not clear how well it caters for the South African variant. And we can't say much of the same concerning the others, like the Pfizer, Moderna, the Johnson & Johnson, the Sputnik V. So more vaccines need to be created, and also probably trying to see if you can switch between vaccines, the same way that you can start on an antibiotic and go on to a generic.
Thank you, Dr. Akiwa. Geturi, do you have anything to add?
I think I'll just agree with Dr. Okia. We don't have enough information. So as she said, in Kenya, we've only gotten one. Okay, the one that's been distributed by government is by AstraZeneca. And I think very, very few people have even gotten their second dose. So there's room for research in this and finding out what impacts mixing and matching will have in the long term. So there's opportunity for, okay, it's a bad thing. I don't think we should experiment with people's lives, but with these new vaccines, we'll just have to learn as we go and adjust accordingly. So one thing I've noticed is there's very little follow-up to the people who have been vaccinated. I don't think we are documenting very well the what are they called? The side effects that these vaccines are having. So it will be very good if we did that, so that we can actually collect enough data to justify any changes in who gets what vaccine. So yeah, that's my take. Thanks.
Maybe just to add on that, there is a database actually where some information is collected after you've taken your vaccine, on which you are able to feed in, and in case you have any side effect, you report on it. But maybe the challenge might come because a lot of it is electronic. It is sent as an electronic in an electronic form, and so depending on people's access to internet and electronics, that might be one of the barriers. But at least as a nation, we have a platform on which they're able to collect data on side effect profile of the AstraZeneca vaccine.
Yes, I completely agree. It probably is that we're going to get a lot of data from our high-income countries, but not necessarily from low-income countries due to the resources. So yes, that's something that certainly needs to be addressed. I think we're heading towards wrapping up time. So I think one last question that has been put to us is, how can we as medical professionals or trainee medical professionals in various specialties help with regards to the public health engagement or engagement re-vaccine hesitancy, or how can we help in this in these issues? Geturi, do you have any thoughts from your working with healthcare professionals and trainees?
Yeah. So I think one thing we need to do is sharpen our skills. For many people, we think advocacy is maybe getting a hashtag trending or going viral, but just beyond this popular social media lifestyle that we are currently think that we are using to get the message out there. We need to also make sure that our offline communication is equally effective, because the movers and shakers might not be on the same social platforms that we are at. So we need to sharpen our skills when it comes to advocacy. Train yourself, attend journal clubs like this, get informed, ask questions, reach out to people who don't live in the same environment as you, get a different point of view, attend courses on advocacy and how to be an effective communicator, because let's not take it for granted that we are good advocates. Let's actually work to intentionally be that good advocate for change. So I think as a last word, I don't know if you'll come back to me, I'd just like to use the NHS as an example. So when it was celebrating its 70th anniversary, I think it was 70, one of the things that came out is it has been a very successful program, but right now it's overwhelmed because the population has really grown, and one of the reasons it's overwhelmed right now, it's because it's been successful, so people are living longer. So we also need to think about, when we are proposing solutions, are we prepared to be successful, and what more needs to be done to make sure that our success can be sustained? Because I think people prepare so much for failure that they also don't prepare for what it takes to sustain success. So let's work at making sure that we build a strong foundation for whatever solutions we are advocating for, so that whether we fail or succeed, progress will be made. Yeah.
So on my part, I always challenge the students and even trainees whom I supervise. Number one, that it is very important to learn the skills within the training that you're obtaining, but it's also pretty important to obtain skills outside of it. For instance, primarily as an anesthesiologist, it doesn't mean I can't know things to do with public health and vaccine equity and such kinds of things. I may not be as a professional in that area, but that kind of knowledge helps. For instance, as we are being, Gatwiri has told us, learn, for instance, advocacy. In communities such as Kenya, where we have very few health workers, we actually pretty much important to our communities. When you go to your community and people know you are one of the few doctors, they have a lot of respect for you. So if you sit them down and explain them these things, yeah, their learning they learn better, they're more interested, they'll even call you to ask you. So in fact, one of the things you'll notice is that a lot of the people within your circles will call and ask you, did you get a vaccine? Did you get any issues with it? What do you think? Do you think I should take the vaccine? And you tell them, yes, you should take the vaccine. So I think even as trainees, we still have that opportunity to influence our communities and influence in our institutions, from our institutions of higher learning even to government. some of these things that we sit and discuss and agree in discuss in, for instance, a journal club, is something that can actually be written in a paper that can actually change and influence practice.
Thank you, Dr. Kiwa. I think that really helps to sum up exactly what us as trainees need to be doing, and Getwiri as well. Really, really great to have both of you here this evening. If you have anything else to add, then please feel free. Otherwise, we'll get things wrapped up. For those of you who missed some of this evening, or maybe have colleagues or friends who might want to watch the journal club later, we record everything and put it up on the GASOC YouTube channel. So it'll be posted. It'll also be sent a link to everybody that had registered. So if you did miss some of it, you'll get an email with the link. I'm just going to share my screen because we've got a couple more slides, but basically it's just going to be a thank you very much to everyone for coming. So if you have enjoyed, or you have anything to say, or you have any further questions that we didn't get around to asking, then please feel free to tweet us, GASOC_2015. We also welcome emails on our website. We've got a comments box. You can tell us what you'd like to see us do and what you like and don't like, or give us feedback. It's always welcome. And also, if you have any specific feedback for the speakers as well, we'll be sending out feedback forms. So please give us your comments so we can pass it on to our wonderful speakers from this evening. And thank you very much for joining us. And for those of you who participated, asked questions, hopefully you enjoyed it as much as we did. Our website is here. We've got a few more events coming up this year, and obviously we've got some more journal clubs. So if you haven't signed up to the newsletter, then you can do so on the website. And Getwiri and Dr. Akiwa, thank you so much for joining us, and thank you for your time and your wonderful thoughts and slides. And also, of course, to Prof. Ashton, who left a little bit a while ago. It was really useful discussion, I think, on a really important topic for us as anaesthesia, surgery and obstetric trainees. It's not necessarily something that we discuss on a day-to-day basis in clinic, but I think the overall message of advocacy in this journal club was one that was really inspiring, I guess, for those of us interested in global health and global surgery and public health, for that matter. So thank you very much, and hopefully we'll see you at our next event.
Sure.
Thank you, everyone.